Guten Tag und herzlich willkommen zu unserem heutigen Webinar zum Thema FOT. Ich freue mich sehr, Ihnen heute unseren Gastredner präsentieren zu dürfen, Professor Raffaele Dellacà, der an der Universität von Mailand tätig ist und im Rahmen seiner bisher über 20-jährigen Tätigkeit als Bioingenieur einen großen Schwerpunkt auf das Thema Atemmechanik beim Neonaten gelegt hat und der maßgeblich an der Entwicklung von FOT beteiligt war. Ich freue mich sehr, möchte darauf hinweisen, dass Sie Fragen bitte zum Ende des Webinars nach dem Vortrag stellen können und freue mich jetzt schon auf eine rege Diskussion. Herzlichen Dank und viel Spaß beim heutigen Webinar.
Thank you very much, Frank, for your introduction. This is my conflict of interest, and this is the outline of the talk. We will start making a short recap on what is the main concept of lung protective mechanical ventilation and respiratory mechanics, and then we will address the challenges and principles of measurements of respiratory mechanics, especially when done at bedside. We will introduce the force oscillation technique as an emergent technique for measuring respiratory mechanics during mechanical ventilation at bedside. And then we will focus on how this technique can help in tailoring ventilation parameters for providing individualized lung protective mechanical ventilation to RDS patients. So the main concept of protective ventilation is based on the application of a low tidal volume with the aim of avoiding lung tissue distension. This concept can be clearly understood if we look at the CT scan of a lung with RDS. As we can perceive by this scan, the actual lung that is ventilated on the subject is much smaller than the overall lung. Therefore, applying a standard tidal volume to this lung may produce over-distension. So the goal is, this concept is called the concept of the baby lung, and the goal is to provide the appropriate tidal volume for the actual size of the ventilated lung. However, the amount of the ventilated lung is variable, not only with the disease, the severity of the disease, but also with the pressure. This is a well-known physiological concept that has been described since mid of the century. And this is a very nice and represented historical slide that shows how the lung can be recruited and recruited by changing pressure. In the upper panel, you can see of this figure, you can see the pictures taken on an excised lung, of the mammal lung, that was completely deflated by applying zero pressure. If we start to increase the pressure applied to this lung, we can see that at the beginning of this inflation, we cannot increase the volume of the lung. It's only when we overcome a critical pressure that is changing between lung to lung, patient to patient, and condition to condition, that we can start to recruit alveolar unit and inflate the lung, as shown by the steep increase of this curve. That means that when we start to increase pressure, for example, above 8 centimeters of water, we can start to see an increase in volume, marked increase in lung volumes. If we continue to increase the pressure, then we get to a third phase of this inflation, in which we can see that despite the continuous increase of pressure, the volume gain is markedly reduced. This is a clear indicator of lung tissue over-distension. So we are over-distending the lung tissue, promoting possibly ventilator-induced lung injury. One other thing that is extremely important thing that this graph is telling us is that this curve is different during inflation and deflation. once we are able to inflate the lung, the pressure that is needed to keep it open is actually much lower. And this is clearly represented by pictures and the graph that is representing the deflation, so-called the deflation limit. So once the lung has been recruited, you can see, we can reduce the pressure and the loss of volume is very small up to a different critical pressure. Then we can clearly see that we are losing volume and the recruitment is occurring at much lower pressure. So bringing back this concept to protective ventilation, when we want to apply the low tidal volume, we need to combine low tidal volume with the most appropriate PEEP, with the aim not only to avoid tissue overextension, but also to optimize lung volume recruitment. If we can make our baby lung bigger, then the same volume can accommodate on a larger amount of tissue and the local tissue stress will be reduced. Therefore, individualizing protective ventilation RDS means selecting the right tidal volume and the right level of the PEEP for each individual patient. Now, let's get back to the pressure volume curve that we have seen before. How can we identify the best settings, ventilation setting, in terms of protective ventilation strategy? So this is the pressure volume curve that we have seen before: inflation limb, deflation beat, pressure on the x-axis, volume on the y. If we look at the CT scans, or if we look also at this microphotographs of the alveolar structure, and we can see that there is a clear region that we call the recruitment, in which we have a very small baby lung. And this, if we try to ventilate the lung in this region, we require very high FiO2 because we have a smaller lung surface that is exposed to gas, to the ventilation, and we are providing a high degree of lung stress. If we go to, in this region, this gray region here, now we are needing lower FiO2 to provide ventilation, but we are still providing a very high lung tissue stress. So the ideal setting for our ventilation will be to have the baby breathing in this region of the curve. Of course, as we have this such an hysteresis, we would like to have the baby breathing on the deflation limb of the curve, where we can get similar slope, similar compliance, similar degrees of recruitment, but with much lower pressure and therefore stress applied to the tissue. So how can we optimize ventilation parameters on the basis of this concept if we have no CT scan available at bedside? What we are doing now is trusting oxygenation on arterial blood gases. However, even if they are an extremely powerful and important parameter, they are not so specifically linked to the degree of lung recruitment and especially over-distension. And this is due to the fact that blood gases are results from so many different processes, from ventilation, diffusion, perfusion, and circulation, that makes this difficult. And multiple to use this parameter for accurately to tune a ventilation parameter. And therefore, and this is also due to the fact the multiple combination of ventilation parameters provide similar blood gases, but have different impacts on lung tissue stress. Another option is provided by the shape of the pressure volume curves that we have seen before. And actually, this is how we define the protective ventilation strategy. This the shape of this curve is represented as characterized by changing in slopes of the pressure flow volume relationship. As we know, the compliance is just the ratio between the change in volume with the change in pressure. Knowing the compliance, therefore, of the lung at the different pressure, standing pressure, would allow us to optimize ventilation. So respiratory mechanics provides one of the most relevant information for tailoring mechanical ventilation. Unfortunately, most of the actual techniques for measuring lung mechanics are limited to the use in research, as they require long, complex, and invasive measurements and time-demanding interpretation. The most accurate and known technology for doing this is the esophageal balloon technique, and as you know, this is very difficult in adults, and pediatric application is extremely complex when applied to neonates. Therefore, only very limited tools are available, especially when the patient has spontaneous activity. We know that all mechanical ventilators reports dynamic compliance, but we also know that when the patients have spontaneous activities, the number, unfortunately, are unrelated. So let's see how can we measure lung mechanics at bedside and optimize ventilation. Let's start to the concept of what is respiratory mechanics. How can we characterize the mechanical properties of the respiratory system? Respiratory mechanics is actually the relationship between the pressures that are applied to the respiratory system and the flow and volumes that results from this pressure. So to characterize the mechanical properties of the lung, we need to apply flow and measure the pressure and see how they are related. Typical approach, and a very simple approach, can be, let's use a mechanical ventilator. We can use a mechanical ventilator to provide a known pressure. We can measure also flow, and therefore we can characterize lung mechanics. This is what is usually done when we measure the dynamic compliance with the mechanical ventilator. The problem of this approach is that it is based on the hidden assumption that the pressure produced by the ventilator is the only pressure acting on the respiratory system. And this is true only when your patient is paralyzed, deeply sedated and paralyzed. If you have the spontaneous activity, respiratory muscles will be generating pressure that is applied to the lung through the pleura. And this pressure will be added on top of those produced by the mechanical ventilator, creating the big issue on how to measure the real pressure that is applied to the lung. Again, either we use the esophageal balloon to estimate pleural pressure, or we need to find a way to exclude the contribution given by the respiratory muscles. Force oscillation is a technology that has been introduced many years ago, back in 1956 by Arthur Dubois, with this specific aim, so to allow the possibility to measure the mechanical properties of the lung, even if the patient was breathing spontaneously, without the need of assessing esophageal pressure. Basic concept behind the force oscillation techniques is we measure the mechanical properties of the system by applying a high frequency, low amplitude pressure variation at the airway opening, and we measure the flow that is consequent to this high frequency component. This is an example of what we can see when we apply this technology to a spontaneously breathing patient. You can see the pressure measured at the airway opening and the flow, and it's clearly possible to identify the slow time varying changes due to spontaneous breathing, and the high frequency components that are applied by the FOT device from the airway opening. These two different signals are clearly different. Again, we can therefore apply some mathematical tools for split the two contributions. This is an example of a one single breath that you can see with the pressure in the upper panel, the flow in the lower panel, one single spontaneous breath, and many oscillations that are produced in this case at 5 Hz, 5 oscillations per second. We can use digital filtering to easily separate the low spontaneous activity, slow spontaneous activity of the patient with the fast activities given by the force oscillation device. Thanks to this, we can exclude the activity of the muscles. So we can delete the spontaneous activity from our data and estimate lung function parameters which are independent from breathing activities. The use of high frequency creates some difficulties in the analysis, and there is a lot of math behind the data processing algorithm in this system. What is important to know to understand and use this technology is that the main result of force oscillation is called the impedance of the respiratory system. And this is the relationship between pressure and flow at high frequency. As at high frequency, we need to consider not only the amplitude of the signal, but also the phase shift between two different signals. To characterize the impedance, we need to use actually two different numbers. One is called resistance, and the other one is called reactance. Usually they are referred to as RRS and XRS for reactance and resistance, respectively. Why resistance is a concept that is well known to all of us, and we represent the resistance of the airways. The reactance is a little bit more complex to understand. Is actually the results of two different contributions. One is the inertia of the system, and one is the compliance. And their relationship is represented in this mathematical form. This is an example to better understand the meaning of these variables. If we represent the lung as made of airways, a tube, and the alveoli that are representing the elastic component of the lung, therefore this balloon connected at the end, but we can use a force oscillation to measure the resistance of this tube and then to estimate the inertia of this tube, which is actually not really relevant to us for optimizing mechanical ventilation, but most importantly, we can estimate the compliance of this balloon. Just to give you an idea of interpretation of data, this is a typical response that you can measure in terms of resistance here and reactance in green as a function of frequency of the forcing signal. If we apply an oscillatory signal, for example, with 5 cycles per second, we will be here. If we apply a signal with 10 oscillations per second, we will be measuring these numbers here for resistance and reactance. If we have an occlusion at the level of the airways, this occlusion will increase the resistance of the airway. So what we are expecting to see is an increase of the resistance, but not a big change to the reactance, because the reactance is related to the compliance of the system and is not therefore affected by this obstruction. Conversely, if we have a lung volume, the extensive lung volume recruitment, what we can see is that the actual lung is getting smaller So we have this baby lung. The lung is smaller here, and the compliance of this lung will be markedly reduced. The consequence on FOT measurements is what you see in this graph. The reactance in green is now shifted downward. That means that if I'm using, for example, 10 Hz, I will see a more negative reactance that is indicating a reduction of the ventilated lung. This is, of course, an easy interpretation, a simplified interpretation. The model that we consider is an oversimplification of the complexity of airways, lung, tissue, and the chest wall, but is actually accurate enough for a proper understanding and interpretation of the data that we are showing you in the next few slides. Well, the advantage of this technology is that this technology can be applied to spontaneous breathing, as the signal we're showing you before, but it can be applied also during conventional mechanical ventilation, as you can see in these tracings in which the ventilator was overimposing to the standard ventilation waveform. You can see the inspiratory pressure and then the expiratory phase. You can see that there is this high frequency, small amplitude oscillation that is overimposed to the ventilation pattern that can be used. This data can be used for estimating the impedance. The same technology can be also applied during HFO, and actually HFO is even easier because HFO is already based on the concept of applying high frequency oscillatory pressures. So we can take advantage of this signal to estimate the reactance without changing the ventilation waveform. So, summary, force oscillation represents a valid tool for assessment of respiratory mechanics during respiratory support, mainly because it is non-invasive, does not require patient cooperation, so it can be integrated in ventilators. It probes continuously lung mechanics, even if in presence of spontaneous breathing, allowing monitoring lung condition at current operating lung volume. This is extremely important. We don't need to change ventilation to test lung mechanics with FOT. So if we can change the ventilation settings and see how they impacted lung mechanics by using this technology. And 3, it is suitable for being easily integrated within mechanical ventilators, allowing bedside monitoring. We don't need anything else than good mechanical ventilators with accurate flow and pressure measurements, which is now commonly available. So it is possible to implement this technology inside ventilators without needing extra connections, equipments, anything that should be added for doing the measurements to the patient. Now, how can we use FOT for implementing and tailoring ventilation parameters following the lung protecting ventilation strategy philosophy? We want to, as we were saying before, we want to ventilate the patient in this region here. So we want to evaluate what happens during the expiratory phase of expiratory limb of a PEEP trial and identify when is what is the lowest pressure that is able to keep the lung open, so to prevent lung volume de-recruitment. So if we use force oscillation in a recruited lung, for what we learn about the meaning of reactance, what are going to expect. If we are applying a low pressure and we have an extensive de-recruitment, we will have a smaller lung, a baby lung. And the force oscillation will measure a very small ventilated lung, means that we are expecting a very negative value of the reactance because of the relationship between reactance and compliance. When we increase the pressure, we start to recruit the lung, and the lung volume recruitment is associated to an increase of the number of alveoli. This means that our baby lung is increasing, getting bigger, and the overall compliance is improving. Reactance will represent this by getting, by increasing, getting less negative, because as you will see, most of the time, reactance is negative. Once we get to the full recruitment condition, further increase the pressure, we start to over-distend the lung tissue. And this will be represented by, again, a lowering of the reactance. So we are expecting to see an improvement of reactance when we recruit the lung, and then a worsening when we start to hyperinflate the lung. Is this what we can get experimentally? Yes, it is. This is an example of a real tracings, of the real tracings taken from a RDS lung. As you can see, we have a very negative value of reactance at the beginning of the trial. The pressure is too low and the volume in the lung is completely recruited. Then we increase the pressure and we see that the reactance improves and continuously to improve. It improves continuously up to about 15 centimeters of water here. After this pressure, further increase in PEEP are not actually providing an improvement in XRS. Actually, the XRS is reducing. And this is suggesting, as we were saying before, tissue over-distension. Once we reach the maximum pressure of the trial, we start to decrease the pressure. We can see that in the first phase, we have a perfect overlap between inspiratory and expiratory limbs of reactants, but then there is a clear distinction between the two lines. And this represents the recruitability of the lung. We can see that we can keep the lung open, in this case, up to 10 with a PEEP of 10 centimeters of water. And with this PEEP, if we are of the deflation limb, now we can provide the best recruitment of the lung at the lowest pressure. If we further decrease the pressure, what happens is that we start to see a drop in the reactance. It is suggestive of the PEEP we are applying is now too low, and some of the alveoli started to collapse, and the lung volume is now reducing, and our baby lung is getting smaller. So in order to validate this interpretation, we ran several studies starting back in 2010. These were done actually together with Göran Stierna and Peter Fricholm in Uppsala, Sweden. And the validation studies were done by using CT scan and simultaneous assessment of FOT. The protocol, we run actually several studies. This is just one of the most representative, in which we studied pigs after bronchoalveolar lavage to simulate the neonatal RDS surfactant deficiency condition. And we ran a PEEP trial with the increasing and decreasing two different phases, the increasing limb and then decreasing limb. For each, this was a stepwise increase and decrease of PEEP, and for each step we recorded blood gas, CT scan, and force oscillations. And here are the results of the analysis that confirmed that the maximum value of the reactance during the decreasing limb of the PEEP trial was associated to the minimum pressure that was able to minimize the amount of non-aerated tissue that is represented by this red line. So if the pressure was kept about 14 centimeters of water, that is indicated as the best pressure for the reactance measurements, we can keep the non-aerated tissue at the minimum values. If we further reduce the pressure, then you can see that the volume, that the lung start to collapse, as shown by the CT scan. We also use the same approach for tuning, tailoring the parameters, ventilation parameters in these peaks during a 24 hours ventilation trial by repeating the FOT measurements and PEEP trials every 2 hours. We compare this approach with the standard approach based on the oxygenation data. And what we found is that if you were only using oxygenation, the animals were receiving a lower PEEP, and actually, as you can see, it's also less variable. There is a low degree of individualization. FOT was actually suggestive of using higher PEEPs, but also the variability was much higher. So some subjects were receiving higher PEEP, some were receiving a lower PEEP, and this individualization was still large, that is represented by the level of standard deviation that you can see in this graph. The blue line is representing the FOT optimized group, and the red line, the RDS net oxygenation-based group for PEEP, of course, in the 12 hours ventilation, first 12 hour ventilation trial. As you can see, this PEEP that was higher was not associated to higher peak inspiratory pressure. So to provide the same tidal volume, even if we were using a higher PEEP, we were reaching lower plateau pressure. And the reason was that by optimizing the mechanical condition of the lung, we were increasing the size of the baby lung, getting this baby lung as big as possible, and therefore our tidal volume was distributed in a larger amount of ventilated lung, resulting in lower plateau pressure. This strategy was also confirmed to be more protective, as the amount of damages that were identified by morphological analysis of the samples at the end of the trial show that the FOT optimized group lungs were much well preserved compared to the other. We have several other studies that were used to further validate this technology. You can see some citation and some referenced. I don't want to get too much in details, but we show that this technology is very accurate also during when applied during HFO. We compare this technology with other state-of-the-art and more complex technique to apply bedside, finding good agreement. But what I would like to share with you is the results that we can get when we apply this technology in preterm babies, mechanically ventilated preterm babies. I have a couple of examples that, in my opinion, are quite representative. This is an example of a recording done on a preterm newborns before the administration of steroids and just before extubation, when the lung was improved. There are two tracings you can see. The black one is acute condition before steroids, and the red one was before weaning, just after, so after steroids. As you can see, it was clearly possible to identify the typical waveform, the shape of the reactance versus pressure that we have seen before, with an increasing limb of this mean airway pressure trial that is moving below the decreasing limb for most of the pressures explored by this trial. The last bit is going that we can see that there is overlap between inflation and deflation, and the reactance is getting more negative with increased pressure. On the way back, we can clearly see the improvement that the reactance and the maximum that is representing our optimal mean airway pressure. By using this system, we can keep the best mean airway pressure in the ventilation setting, and we can repeat this test with time to continuously tailor this parameter. What happens when the lung start to be stable is no longer derecruited. Well, what we see is the line that you can see in red here. So you have a less negative reactance that is showing that the lung is now fully recruited. And when you increase the pressure, you have just a small tendency of getting more negative because of the distension of the tissues. And you don't see the hysteresis that is clearly present when you have lung volume. So you can use this technology not only to optimize the pressure for each single PEEP trial, but also to monitor how the lung of this patient is evolving, if it is improving or not. And this is actually what we did in a case study that we published a few years ago on a patient with H1N1 that was receiving ECMO. This is another interesting example of what the force oscillation can tell you when you have limited possibilities to infer information about lung recruitment from oxygenation. This is always the same graph in which we have PEEP on the x-axis and the reactance on the y-axis, and the different colors here represent different days and the evolution of the lung condition of this patient. The first test was done in severe acute condition just after initiation of ECMO, and as you can see, the tracings were showing that whichever pressure was applied over the minimum pressure that we were using of 6 centimeters of water, whichever pressure was applied was resulting in a negative change of reactance. This was suggestive of no recruitment. The lung was flooded. There was no way to recruit a significant amount of the lung, and therefore we were keeping the pressure at the PEEP very low because there was no use of having an increased PEEP in this condition for this lung. After 1 day and some treatment with bronchoalveolar lavage and done with surfactant, we were able to start to see first sign of recruitment. You can see for the gray lines that we had an increasing and decreasing trial showing that the decreasing limb was providing higher values for reactance, and the maximum in this case was at 10 centimeters of water. So we kept this PEEP and we repeated tests in order to always provide the best PEEP, and this helped the lung to reopen and to get more stable. You can see the next measurements that we are reporting is the blue one, in which we can see that there is no longer this tendency to get negative with increasing pressure, suggestive of a stable and recruited lung, but we were also always seeing some reduction of the reactance at low PEEP, suggestive of still a tendency of the lung to collapse. The last measurement we have done was showing now a very stable lung for a wide range of pressures, and therefore we decided that the baby was ready to be weaned, and it was actually successfully weaned from ECMO and then supported as usual. In this graph, you can also see how we expect to see different tracings when you have patients with other conditions than RDS. In these graphs, we are reporting PEEP trials results in terms of resistance and upper panel and reactance lower panels in patients with healthy lungs, in patients with RDS, and also in patients with BPD. And what you can observe is that the healthy lung has a behavior like the one that we have seen when in the other patients when they were ready to wean. So we have a reactance with almost no hysteresis, up and down are moving more or less on the same line, and the resistance is also slowly changing with time with a PEEP, with a small tendency to decrease. That is the well-known effect of increasing airway diameter when we increase lung volume. RDS, we see the same figures that we have seen in different cases before, with an increasing limb that is moving lower compared to the decreasing limb at the maximum that can be identified at the best PEEP for protective ventilation strategy. For BPD, we have totally different behavior. As you can see, instead of having a clear dome, this is actually the average of several patients. So individual level, you will see even more sharp identification of the maximum. What happens is that you can see that both resistance and reactance can be very different at low PEEP, and then they stabilize, they get normal. You can see reactance in RDS, resistance in RDS didn't change markedly. So why this is happening? Because in these BPD patients, we had some obstruction at the level of the central airways, probably due to loss of elastic recoil of the lung. And this is clearly identified by these huge negative values that are both on the inflation and deflation limbs in the reactance associated to increase the value of the resistance. We have some other literature that be happy for you to read, showing the usefulness of this technology when tailoring mechanical ventilation in preterm babies. We are also exploring the diagnostic capabilities of this technology. So we can use the technology not only to understand which is the best pressure for the ventilator settings, but as we can say, we already observed, for example, the ECMO case, we can also track what happens day by day. We can use this as a lung function tool to evaluate the condition of the lung of our baby and to track how they change as a consequence of different intervention. So we also published data showing that force oscillation can be useful to improve our prediction on respiratory outcomes in extremely preterm newborns. The respiratory mechanics actually is an important information that allows you to understand the severity of the condition of the baby. And we are also exploring the possibility to using this technology for evaluating response to treatments. For example, in these cases, we have patients with BPD that were tested for bronchoreversibility. So we gave bronchodilators to the patients, and we were able to identify those who were responding. You can see the green line is before bronchodilator, and the black line is after bronchodilators. The resistance on the top and the reactance on the bottom. For one representative patients who responded to bronchodilator. So in this case, you know that this patient can benefit from this kind of treatment. And this other patient was not responding, and as confirmed by the same value of resistance and reactance obtained before and after the application of this intervention. So you can use this technology also to evaluate the effect of your intervention. As a final information, I would like to share you some tips if you are going to use measurements with the force oscillation in mechanically ventilated patients. We always need to remember that even if a simple technology to apply it, not simple technology per se, but it's simple to be applied at bedside because can be highly integrated to mechanical ventilator. The execution of the test, the interpretation of the results, as all physiological measurements techniques require some care, and you always need to have a clearly mind what you are going to do and what you are doing. So first of all, when we measure the mechanical properties of the respiratory system with the force oscillation, always remember that the device is measuring the impedance of everything that is connected to the Y piece. And this includes also the ETT. So if you change in the same patient, ETT, diameter or length, what we are expecting is that also that the measurement the ventilator will be providing you will be different. However, if you make a change in the ETT, this will be a change that is the same whichever PEEP you are doing, because the ETT is not changing with PEEP. So what you are expecting is that the curve will be shifted, but the maximum will be always indicating you, which is the optimal pressure. Another important point is we are measuring all the mechanical impedance. This means that if you have obstruction of the tube or in the bronchi due to secretion, or if you have, for example, a misplaced ETT that is touching on the trachea wall, this will result in decreased XRS, which are not reflecting the status of recruitment of the lung. If you have a bubbling ETT, what you are going to measure is the mechanical properties of something that is completely different from a clean lung. So before doing a FOT test, it's important that you are sure that the tube is well positioned, and eventually, if there are many secretions, it's better to do a suction. Some fast inspiratory efforts may corrupt force assessment. If the baby has many breathing efforts, is doing fast motions and changes, we need to repeat the test. It's something very easy. FOT test requires only a few seconds. So if you are, if you can see the baby that is moving during this test, and you may have suspect that some fast changes may affect the quality of the test. If you want to be sure that the test is good, is well done, you can just simply repeat the test before moving to the next PEEP step. If you repeat the test and the measurement will be reproducible, so similar to the previous one, you are sure that the test is done properly. So sometimes it's very good idea to repeat the test, especially when you see strange behavior of the curve, that shape of the curve that you are producing. Another important point is that we need to remember the lung volume history affects lung volume recruitment. This is actually what we discussed for the majority of this talk. If we have major leaks or disconnections during the trial, if we have that the pressure that we apply to the baby is changed, even transiently is reduced, we know that this might lead to the recruitment. And even if we resume to the same tip level, we will be losing the recruitment effect of the inflation limb of the trial. So in case you have any of major leak disconnection, so if the pressure cannot be kept stable during all the execution of the PIP trial, you need to restart the trial from the beginning. You cannot just resume by reconnect or reduce the leaks. And this last recommendation, we need to remember that the FOT tests report the mechanical condition of the lung at the current ventilation setting. If you change tidal volume, respiratory rates, or whichever other ventilation parameter, you also need to repeat the test and adjust PIP, because when you change the mechanical, the working condition of the lung, these changes will affect also lung mechanics, and therefore the optimal pressure might be different. This is not something related to FOT per se, but it's just a physiological consequence of the changes that you apply to the system. In conclusion, the delivery of an effective protective and mechanical ventilation requires the continuous tailoring of ventilatory parameters on every single patient. And we think that FOT represents an effective bedside tool for supporting physicians in understanding the mechanical condition of the lung, for tailoring PIP during conventional ventilation and or mid-airway pressure during HFO to maximize lung volume recruitment while minimizing the risk of lung tissue over distension, therefore implementing the best strategy for lung ventilation, lung protective ventilation strategies. But we also think that FOT can provide continuous assessment of respiratory mechanics parameters, and this is helpful for identifying changes in patient condition and response to treatments. As a last slide, I'm leaving some references. That these are several studies that are supporting the concepts that we discussed during this talk. This is my last slide with acknowledgements of the several contributors to the studies. We have very lucky in being able to run many studies together with different groups in the different parts of the world. And these are also the acknowledgement of my team of the TechRes Lab Polytechnic. I think we can now open this for discussion, if you have questions.
Thank you, Raffaele. It's really great and impressive lecture about FOT technique. And in the chat, actually, we have no question. And I'm surprised how to ventilate every day in hospital without FOT. And it's a really interesting topic. And do you have some experience in which countries FOT is actually used? I never saw it in Germany. And in one hospital, we make a trial, but every day it's not seen in the hospital.
So as this technology has been available on commercial devices since not such a long time, there are only few centers that I am aware of that are running using FOT for not for research studies, but for clinical evaluation of patients, and especially the one that has the most wide experience, to my knowledge, is the neonatal intensive care in Monza, and also in the neonatal intensive care in Mangiagalli Hospital in Milan. They are using FOT to evaluate lung function, especially in patients with diaphragmatic hernia or also during ECMO. So I know that there are several centers in which they are running studies for evaluating the possible uses, other uses of FOT. And in such centers, they are also starting to introduce the technology on more regular clinical activity. But this is an ongoing process, to my knowledge.
Okay. How was the experience in the hospital when they started with FOT and find there's another way to find the best PEEP or MAP?
So there is a lot of interest, of course, and they are enjoying not only the possibility to optimize PEEP, but they are also exploiting a lot the possibility to track how the condition of the patient changes, the mechanical condition of the lung changes with time, day by day. So what I'm saying that even if the first application for us was the identification of the optimal PEEP, it seems that there is a lot of enthusiasm going on, also growing around the possibility to see how these parameters are changing day by day.
Okay. We get one question now. Can you see this in your screen? How does FOT work in non-uniform lung?
So FOT, this is a good question. FOT is a way to measure the overall behavior of the lung. So if you have a diseased lung, this lung is most of the time behaving in a inhomogeneous way. So the diseases are always affecting the lung, making its behavior less homogeneous. So what we measure is the amount of the lung that can be ventilated with a fast time constant. That means the part of the lung that can receive the gas, the air, and during each tidal volume. And if there are some parts of the lung that are characterized by less increased, increased resistance or the recruitment, these are seen by FOT as part of the lung that is not contributing to ventilation. So this is, if you use the single frequency FOT like the one that we implemented with the actual ventilator, the inhomogeneity cannot be detected, but they contribute to understand which is the best mechanical condition of the lung anyway. FOT is used for in adults or pediatric applications when it's used for lung function test. Is applied usually by using several frequencies. So there is no only single frequency like we do in ventilation, but there are more frequencies, and the frequency dependence of these parameters can provide information also in the degree of heterogeneity in the lung condition. But this is something that we are not addressing for a specific application.
Okay. There is no other question. Okay. I think, thank you very much, Raffaele, and thank you very much for attending this lecture. And I hope I see you soon in Montreux.
Sure, yes.
Okay.
Definitely.
Everyone have a nice evening, a nice afternoon where you are, and thank you very much. Bye-bye.
Thank you. Bye.